welcome to the closing event of Psyche, which is Science Gallery Bengaluru's 5th exhibition season. For those of you joining us for the first time, Science Gallery Bengaluru is an institution for public engagement with science, and we are a part of an international network of galleries and founded by the government of Karnataka. We work very closely with the Indian Institute of Science, National Center for Biological Sciences, and the Srishti Institute of Art, Design, and Technology. I would like to extend a really warm welcome to Professor Vikram Patel and Chris Gopalakrishnan. We will hear Vikram speak to us this evening about reimagining the path to recovery. But before I invite him to deliver the public lecture, I would like to invite Chris Gopalakrishnan, who is also a member on our board of directors. He's otherwise the chairman of Axelor Ventures, an accelerator that helps startups during early stage of their business journey. Mr. Gopalakrishnan has served as the vice chairman of Infosys from 2011 to 2014, the chief executive officer and managing director from 2007 to 2011, and of course, as most of us know, was one of the co-founders of Infosys. In January 2011, the government of India awarded Mr. Gopalakrishnan the Padma Bhushan, the country's third highest civilian honor. He holds master's degrees in physics and computer science from the Indian Institute of Technology, Madras. He's a fellow of the Indian National Academy of Engineers and an honorary fellow of the Institution of Electronics and Telecommunication Engineers of India. Thank you very much, Chris, for agreeing to deliver the closing remarks for our exhibition season today. Over to you.
Thank you, Janvi. Let me add my welcome to everyone. I would like to thank everyone who has joined us here today for the closing lecture of Science Gallery Bengaluru's first exhibition of the season 2022, Psyche, a much needed program at this time. A special thanks to Janvi for giving me this opportunity to share my thoughts, and I'll come back to this. For why special thanks, because this is an area of interest to me. With our growing population and an aging population, of course, India is struggling with the health burden from escalating neurological and neurodegenerative and psychiatric disorders. The pandemic has further exacerbated this, making the gaps in our healthcare systems even more apparent. There's not just a lack of infrastructure, but also a lack of fundamental and applied research investigating the biological and sociological factors involved. Alongside this, we also require greater public understanding and empathy for mental health conditions to reduce the social stigma still associated with them. I'm especially committed to supporting foundational research and longitudinal studies on the brain and neurodegenerative studies. As I said, this is an area where I have been investing my time, my money, supporting research at IISc, IIT Madras, NCBS, and other places, both on the computational side as well as on the clinical side. I'm on the computational side interested in understanding the brain and creating new models of computing from our understanding of the brain. It's fascinating to learn that two of the people who are considered as, let's say, fathers of computer science, if I may say so, are von Neumann and George Boole. Von Neumann came out with the von Neumann architecture, which said, there's a separate area where computation is done, another area where storage of data happens in a computer, and we created the von Neumann architecture. Similarly, George Boole came up with the Boolean algebra, which is the binary numbers and the algebra around binary numbers and things like that. It's interesting to learn that both of them got fascinated by the brain, So George Bolt thought that in the brain, there are separate areas for storage and processing. And sorry, for Newman. And George Bolt thought that since we are logical people, brain must be working with binary logic and things like that. Both were wrong, but the entire field of computer science was built on these false assumptions. So it's fascinating that we still continue to wonder about the brain. The whole field of, for example, deep machine learning, again, is inspired by our understanding, or if I may say so, our limited understanding of the brain. So that's on the computational side. On the clinical side, of course, aging is something that we may be able to slow down, but we cannot stop. And as people age, and the entire world is aging, India is also aging, we live longer. And many people, it's estimated that maybe 1 in 5, 1 in 6 may develop some form of neurological disorder. And the social costs associated with these are very, very high. And so I support research on new models of computing as well as on aging and aging-related neurological disorders. And that's what fascinates me. And that's why I said special thanks to Janvi for giving me this opportunity to share my thoughts. Brain is the last unknown, or one of the last unknowns. We still have not fully figured out, how the brain functions at different levels fully. Some understanding is there, of course, but fully we have not understood. And so it is critical that India participates in this global research endeavor to understand the brain. Several countries have large initiatives around brain. And understanding the brain is critical from a disease perspective, from a health perspective, and understanding the brain is also important from computational sciences, computer science perspective, AI, machine learning perspective. So I'm pleased that Science Gallery Bengaluru's exhibition season this year started with Psyche and has succeeded in bringing several of these ideas to the forefront of public discussions. Through more than 90 programs over 45 days, the exhibition has explored cutting-edge research aligned with social concerns. The session with Lincoln Center, New York on music and dementia addressed how the arts might become a form of care for those with neurodegenerative diseases. Sessions in the lab with researchers from NIMHANS and NCBS dove into the latest work done with stem cells to study neurological diseases as well. The exhibition skillfully places research from India in the global context and brings together arts, science, and lived experiences. Psyche also explores the speculative futures around the brain and the mind with fascinating talks and exhibits around artificial intelligence, neurotechnologies, and machine psyche. By bringing together not just neuroscientists and psychiatrists, but also historians, physicists, artists, and others to share their knowledge, Science Gallery Bangalore has begun an inclusive and open-ended conversation on research around mind and brain. Clearly, a interdisciplinary, multidisciplinary area of understanding the brain, research on brain, and if we come with solutions that will also require multiple disciplines. I look forward to hearing Professor Vikram Patel's lecture today evening on what is needed to reimagine and revitalize our mental health care systems, something we are starting to work on at this point. I also invite all of you to continue actively engaging with Science Gallery Bangalore and support them as they build a vibrant public dialogue on science. I believe that Bengaluru is fortunate to have the Science Gallery here. It's a public space where we can engage with science, with technology, with future, and from a multidimensional perspective. So please get engaged and support them as they develop this. Thank you, and over to you, Janvi. Thank you.
Thank you very much, Chris, for your kind words and for your continuing encouragement. You've been supporting us now for a few years, and I look forward to continuing work with you in this area, but also others. Now, to the public lecture for this evening. It gives me a huge pleasure to introduce Professor Vikram Patel. Vikram Patel is the Pershing Square Professor of Global Health in the Blavatnik Institute's Department of Global Health and Social Medicine at the Harvard Medical School, an adjunct professor at the Public Health Foundation of India, an honorary professor at the London School of Hygiene and Tropical Medicine, and equally important, he is the co-founder of Sangat, an Indian NGO, which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008, and the WHO Public Health Champion of India Award in 2016. He is a co-chair of the Lancet Commission on Reimagining India's Health System. I cannot imagine having a better interlocutor for the concerns that we've tried to raise through the exhibition season. And it is a privilege to have you deliver the closing lecture. Over to you, Vikram.
Thank you very much, Janvi. Thank you, Chris, and thank you to all the folks at the Science Gallery for this wonderful opportunity for me to speak to you this morning from Boston. And I know good evening to all of you who are joining in India. I've been thinking a lot about the subject of this lecture today. And I hope that what I will do today is not only to give you a sense of why we need to have a completely new way of thinking about mental health care, but that this is perhaps the most urgent moment in our history to do so. It's urgent because the world has been experiencing a mental health crisis well before the pandemic. This is a crisis that disproportionately has affected those who are already on the margins of society, from low-income groups to LGBTQ+ persons, to those who have been exposed to the horrors of war as we see currently unfolding in Europe and Afghanistan, and intimate partner violence. Our young people, arguably the greatest human resource asset of any society, the ones that economists will consider the dividend of every society, are especially threatened because most mental health problems begin during this period of life. More than 3 out of 4 cases of mental health problems we see in adulthood have their onset before the age of 24, which is why this period of life is, developmentally speaking, the most important and sensitive phase of the life course when it comes to our mental health. Now, some of you may wonder, why do I say there's a crisis? Well, the crisis is defined in many different ways by a range of different metrics that people use, the most common of those being the prevalence. How common is a mental illness? How common are substance use problems? And how common is self-harm and suicide? Based on these metrics, I can tell you with great confidence that the situation was worsening in most countries around the world, including in India, even before the pandemic, which has only added a lot more fuel to the crisis that I described was pre-existing. Now, there are obviously many causes of this crisis, one of which is the increase in the risk factors in the population. Adversities in one's social world contribute immensely to the risk of mental illness, especially adversities during the earliest years of our life, when our brains are most plastic and most sensitive to the environment. But mental illness also has adversities as its consequences, setting up a vicious cycle between adversities in one's social world and poor mental health. Now, no one can question the worsening of some of the most pernicious social factors in the past decade, including those that have been fueled by the pandemic, as well as, of course, the looming threat of climate change. Moreover, as I have observed over the course of my career over the last 3 decades, working as a psychiatrist, in both wealthy countries such as Britain and Australia, but also less wealthy countries such as Zimbabwe and India. Unlike almost every other human ailment, from diabetes to cancer, from TB to COVID, all countries have singularly faced to address the vicious cycle between social adversities and poor mental health. All countries have failed to bend the arc or shift the needle on the burden of mental health problems. But in addition to the increase in risk factors, there is also, very importantly, the dramatic erosion of protective factors. We know that most people who live in conditions of disadvantage and deprivation actually enjoy good mental health. And therefore, this speaks to the importance of protective factors in our lives. Most importantly, social connectedness and capital. And around the world, there has been a decline, an erosion in these protective factors due to a variety of reasons. For example, the dramatic increase in polarization and hate in countries and societies around the world, the loss of trust in the state, and neoliberal economic policies that have led to a dramatic increase in wealth and income inequality. We know that a more unequal society is exactly the kind of society where the fabric of social connectedness is torn. As Tom Insel, my good friend and the former chief of the National Institutes for Mental Health in the US, which is the single largest research funding body for mental health in the world, he just published a wonderful book specifically about the mental health crisis in the US, and the book is called Healing. And he describes in this book that every single metric reflecting poor mental health has worsened in the US, despite the US spending more on mental health care than for any other health condition. Here's the interesting fact. The US spends more on mental health care than on cancer care, than on diabetes care, than on cardiovascular disease care. The US also enjoys more mental health resources per capita than any other country, and spends over $20 billion in research in the period when Tom was director of the NIMH. And in spite of all this money and all these specialists, every single metric, the prevalence of mental illness, the proportion of people with mental illness who are incarcerated in US jails, the proportion of people with mental illness who live on the streets as homeless individuals, the suicide mortality rate in the US, all of these metrics have gotten worse in the last 2 decades, in stark contrast to the progress made in every other domain of medicine. The increase in the burden of suffering due to mental health problems is, of course, not just because of an increase in risk factors and a reduction in protective factors. It is also because of the failure of our healthcare system to care for people with mental health problems. And this is the subject of my lecture today, the crisis of care, because at the heart of the mental health crisis is indeed the crisis of care. Now, to most people, given what I've just described, it seems like as if no amount of money that we spend, no amount of mental health professionals that we have, every single metric is getting worse. The US being, of course, the outstanding exemplar of that observation. To most people, it is plainly evident that this crisis must require us not just pouring more money, but to interrogate the core assumptions underlying our understanding of the nature of mental health problems and the architecture of the mental health care delivery system. And at the heart of this interrogation, friends, I would argue, is the biomedical framing of mental health through the lens of mental disorders. Now, before I really look at this particular issue in more depth, I need to have a brief historical detour so you understand how we landed up where we are today. Now, up until the 1960s, psychiatry was dominated by 2 very different traditions. On the one hand, you had the traditions founded on the thinking of Freud and psychoanalysts that followed him, basically a tradition of psychoanalysis which dealt primarily with talking therapies that were intended to help people with difficulties in their day-to-day lives, personality issues, and mood and anxiety conditions. On the other hand, you had a totally different tradition that was focused on the needs of people with serious mental disorders like schizophrenia. And this focused primarily on social inclusion in the workplace, in the community, in their homes. Two very, very different traditions. On the one hand, you had a tradition, the psychoanalytical one, that focused on the inner self, on the inner psychological well-being, the personal history of the person, focusing a lot on early childhood, for example. And on the other hand, you had a community-facing perspective that focused on the social structures which influence recovery. In both perspectives, though, there was one thing in common. The focus was on the person, either their psyche or their social world. In the 1970s, the psychiatric profession took a very important, historically the most important turn away from its original moorings, from its original focus on a person-centered framing to a very narrow biomedical conceptualization, primarily to align the field of psychiatry with the rest of medicine. What was at the heart of this reconceptualization? It was the adoption of a classification system which bucketed people into diagnostic categories, typically dividing the population into people with and without a mental disorder, and furthermore, within the mental disorder category, further classifying them into sub-buckets of depression, anxiety conditions, or disorders, schizophrenia, and so on. Now, of course, this was the system that dominated medicine. If you consider infectious diseases, this is exactly what we do. We diagnose people not on the basis of their psyche or their social world, but on the basis of a pathogen. We have TB, we have COVID-19, we have malaria, HIV, and so on. But unlike these other diagnoses in medicine, which were based on specific signs of disease, which could be verified by a medical examination or a laboratory or a radiological test, like an X-ray, all psychiatric diagnoses were based on clusters of symptoms that were based on patient reports to psychiatrists in academic hospital settings. Now, even though there were structural flaws in this approach at the outset, because think about this, these psychiatrists were not all around the world, and the settings they worked were not the typical mental health care settings. In fact, psychiatric diagnoses were almost entirely based on observations that were made by a handful of academic psychiatrists in rich countries, read that as primarily the US and Britain. They were based on what these psychiatrists in these very, very creamy layer settings saw in their highly specialized clinics. Of course, these categories completely obscured how mental health problems were experienced by over 90% of the world's population. Still, one must grant to these early architects of the modern biomedical system of psychiatry that they genuinely and fervently believed that this symptom-based categorization, while completely primitive compared to other branches of medicine, if we were able to research these symptom-based clusters, that we would ultimately discover the biological or genetic heart of what each of these diagnostic syndromes or categories were. Well, and of course, there was the assumption that once you discover the biology, we would discover the holy grail, the medication that would transform these conditions. Well, 50 years later, and tens of billions of dollars invested in biological research later, we are no closer to finding this holy grail for any mental health condition, any, from autism in childhood through to ADHD, depression, anxiety, substance use conditions, schizophrenia, bipolar disorder, all the way through to the neurodegenerative conditions in later life that Chris spoke to. We don't know any of these conditions any better now than we did even 50 years ago when we speak specifically of key issues like biomarkers for these conditions or indeed any dramatic new therapeutics. If anything, as I mentioned before, every single metric of mental illness has only worsened over these last 50 years. So to return to the big question, confronting the field. Why do we have a mental health crisis? Friends, I will argue today that the overarching reason is that we have focused incorrectly on a narrow binary biomedical framing of mental health, which divides people into people with and without a mental health condition, a framing which has worked very well for TB and cancer, but is hopelessly inadequate to explain the complexities of the human experience of mental health problems. The result of this framing has been an overwhelming emphasis on narrowly defined clinical interventions as the solution to mental health problems, with no attention to prevention and care programs to social determinants. Furthermore, this approach, which focuses on diagnoses in adults, misses the unique opportunity of a life course perspective, which, as I mentioned earlier, embraces and acknowledges the fact that most mental health problems begin in adolescence and young adulthood. The emphasis on diagnoses and medication translates into a singular reliance on prescribers who are mental health professionals, basically psychiatrists, who are not only very few in number, but are extremely expensive to train. And of course, as a result, mostly work in the big cities or in the private sector, out of reach of the vast majority of people in India and indeed around the world. This supply side challenge is further amplified by demand side challenge. It isn't the case, as we've seen in the US, that simply having more psychiatrists is going to solve the problem. There is also a demand side challenge. What is that? The reluctance of people to seek help from mental health professionals, not only because it's expensive and often difficult to access from where one lives, but also because the narrow biomedical diagnostic perspective is not aligned with the personal narrative of the problem. Rarely have I spoken to anyone in India, particularly outside the affluent upper classes of the big cities. Rarely have I found an individual with depression or anxiety who views their problem through a biomedical lens, who says, I have a psychiatric condition called depression. Very, very rarely. Most often, the framing is a personal narrative one. I am not sleeping well at night. I cannot think clearly. I am feeling hopeless about my future because my husband is drinking a lot, because he's beating me when he comes home at night, because my son is not doing well in his work, and a variety of other social framings. And of course, the other very important reason for a demand side challenge is the long history of incarceration, of violence and sedation associated with mental health care, and I'll return to that point in a moment. Friends, furthermore, the narrow biomedical model, by privileging the mental health professional expertise, disempowers available resources in the community. By vesting all power and money for mental health care in the hands of a tiny number of psychiatrists and psychologists who dominate policy making, and like other medical specialties who have assumed power over every aspect of the mental health care delivery system. Let me switch then to what the future should look like. And I want to propose 4 key paradigm shifts, 4 dramatic shifts for reimagining our approach to mental health. First, as I have already argued, it is obvious that we must look beyond narrowly defined and diagnosed mental illness. We need to do this because we need to embrace the rich body of neuroscience that clearly demonstrates that there is no boundary in nature between mental illness and not having a mental illness. That in fact, all mental illnesses are, in essence, extensions of the range of normal human thoughts, emotions, and behaviors, which every human being will experience at every moment of their lives. This implies that care needs to be triggered not by a diagnosis, but by personal need. And by doing so, we break down the artificial boundaries between prevention, early intervention, care, and recovery. I'll return to practical examples of each of these paradigm shifts in a moment. The second paradigm shift is that care must be defined not only by narrowly defined clinical interventions provided in a facility, a health facility, which is typically focused on symptoms like hearing voices or feeling suicidal. It needs to extend beyond that. Of course, this is a really important focus, but it has to go well beyond that to address what people want. And this is typically supporting psychological healing and the social needs that people experience that are intertwined with their mental health, such as broken relationships and financial difficulties. This is, of course, the hallmark of what we call person-centered care, which recognizes that the goal of care is not just symptom relief, but is recovery as defined by the person receiving care. As Tom Insel beautifully describes in his book, Healing, that what most people want and need relates to three things. He calls them people, place, and purpose, 3 Ps. People refers to the connection that we need with other people in our communities. Social connectedness, friends, I argue, is the fabric of mental health. The second P is place. This is about being able to live in a place where one feels secure, both emotionally and practically, literally a place which we can call home. People and place. And the third P is having a purpose in life, a meaningful purpose in life. And it is the lack of people, place, and purpose that Tom very evocatively argues has been the driver for what is perhaps the single biggest health crisis in the US in the last 2 decades. The deaths of despair, which has led to the falling of life expectancy in the US, driven entirely by substance use and suicide-related mortality, primarily affecting working age Americans in the large Midwest and Rust Belt of the country who have lost social connectedness, who have lost their homes, and who have lost a meaningful purpose in their lives. Further, we need to expand our focus on just accessing care to ensure its quality. Most care, friends, most mental health care in India today, and indeed around the world, even when a person accesses that care, it falls far short of the evidence of what works. There is far too much irrational and unnecessary use of psychotropic drugs. And when psychological therapies are used, they're often without any support in the scientific domain. This means that even when people access care, which is in itself pretty uncommon, they don't get what actually works. Third, we must meet people where they are, rather than expect them to travel often long distances to where the mental health professional is. This, of course, means we need to integrate mental health across sectors, focused on building care systems in places where people are, in communities, in primary care, and these days, digital platforms such as telemedicine. The mental health care system must strive for a coordination of care between all these different sectors so that we don't have people falling between the stools. These important sectors include the specialist sector, primary care, and social services, so that we can create a seamless continuum of care. This paradigm shift requires that a person is accompanied on their journey to recovery, and no psychiatrist is going to do that. And for that, we therefore need to democratize knowledge and skills to empower community-based providers and to transform care provision from what is currently a doctor-led approach to a team-based approach, with equally important roles being ascribed to diverse providers. And I want to emphasize here a point I'm going to come to next, which is the importance of peer-led services. Services led by people with the lived experience of mental health problems. So the third paradigm shift emphasizes that long-term recovery requires not just early intervention, but long-term support. And this in turn requires health systems which value, finance, and empower community and grassroots actions as critical components of the mental health care system. The final paradigm shift, the fourth, and for me, perhaps the most important, is that we must emphasize social justice and equity to reduce the historic disparities and coercion that we see in mental health care. Now, while all the other three paradigm shifts I've spoken to really relate to a person's right to quality care, it is evident there are also other fundamental basic rights that have been systematically denied to persons with mental health problems. And these are the rights to freedom, to dignity, and to inclusion. The right to freedom, to dignity, and inclusion. And of course, the right to be heard. These are the rights that have been championed by movements of persons with disability and mental health professionals. These groups typically call mental health problems psychosocial disability. These groups have shone the spotlight on the cruel and inhumane ways in which people with intellectual disabilities and serious mental illnesses have been treated across history, over the millennia, across sectors of care, from traditional to current to contemporary biomedical systems, and across geography around the world, right up to modern times, where incarceration, involuntary and coercive treatment in both traditional and psychiatric care facilities is yet too commonplace. There is exclusion and denial of basic civil rights in too many countries. Even in the most progressive societies, these are the reasons why people with mental illness experience scandalous levels of premature mortality. You know, mental illness in and of themselves are not like cancers. They're not lethal conditions. And yet, people with schizophrenia die 20 to 30 years earlier than other people in their communities. This is a scandal. And the reason for this is largely due to the structural violence that people with serious mental illnesses experience in their daily lives, including the lack of access to fair employment and housing, and lack of access to quality medical care for the chronic conditions that they often experience, like diabetes. It is clear to me then that the right to access to good quality care must be aligned with the right to freedom, dignity, access, and inclusion. Agency and inclusion. And it is through the realization of these rights that the elephant in the room that we all talk about, the stigma and discrimination experienced by people with mental illness, will ultimately be put to rest. Friends, so many stigma campaigns talk about changing the hearts and minds of people by having a mass media campaign, wonderful slogans, very, celebrities talking about mental health. I support all of that, but it is completely insufficient. Why will stigma and discrimination against mental health care and people with mental illness disappear if the way mental health care is delivered is associated with violence, with involuntary care, with coercion, with incarceration, and with sedation that transforms you into becoming a zombie? What we need is a transformation of our mental health care system if we're really going to address stigma and discrimination. And to do so, we need to emphasize the centrality of the lived experience in diverse ways. People with the lived experience must be partners in the design, the development, the implementation, and the evaluation of care. They should be central to shaping policy decisions and holding the mental health care system accountable. I want to end my lecture with really describing how we can operationalize these paradigm shifts. And to do that, I'm now going to turn to the work that I have led over the last 2 decades. My own work in these last 2 decades has been increasingly guided by these assumptions that I have referred to, the reimagining of the way we think about mental health and the architecture of the mental health care system, starting with a rejection of the narrow biomedical framing of what I call the 3Ds. Tom spoke about the 3 Ps that people need. I speak about the 3Ds that we need to reject. The 3Ds of doctors, diagnoses, and drugs. These are, of course, important, but only for a small group of people with mental health problems, and a focus only on these 3Ds has led to where we are today. We need to reject these 3Ds to address the disparities and injustice experienced by people with mental health problems, of the denial of access to quality care, and the fundamental rights that are needed to support their recovery. I wrote a book, Where There's No Psychiatrist, in 2003, inspired by the ideology of leveraging community resources to deliver health interventions, something that India should be so proud of, because it has been the home in which these innovations originated decades ago, innovations that today are being widely embraced around the world. When we think about the great knowledge that India has produced, it is ironic that we think only in narrowly defined ways about things like vaccines and technology. Of course, we've done so well in those kinds of knowledge generation sectors. But friends, I would argue that the way India has innovated in its villages, in its towns, in its least resourced communities, to use resources that are already available to do transformative things, to leverage community-based manpower to transform healthcare, is perhaps one of the greatest innovations to come from our country. This was so beautifully documented in one of the books that has been so influential in my life, the book edited by Professor Antia, one of the great medical practitioners who really transformed healthcare in this country, a plastic surgeon who showed that reconstructive surgery for people with leprosy was insufficient to improve their lives. One had to work on inclusion of people into their own communities to transform their well-being. And the book, People's Health in People's Hands, that documents dozens of different examples of these innovative practices stretching back to the 1960s, is a must-read if you want to think about how we can reframe mental health in our country. But I knew that we needed more than just ideology, and examples from other fields of medicine like maternal and child care, TB care, and the care of people with leprosy. We needed more than just ideology to influence policy and practice in a field, the field of mental health, where there was such a huge asymmetry of power in the hands of the medical profession and the pharmaceutical industry. So I set about working with my colleagues in Sangat, the NGO that I co-founded back in 1996 in Goa, which now works across the country, to build what is today the largest body of empirical science on the design and delivery of psychosocial interventions for the prevention and care of mental health problems, which deploys lay people and community health workers in routine care settings and does not use a diagnosis-based model to deliver psychosocial interventions. This body of science complements the work by global mental health researchers and practitioners around the world, particularly the developing world. And this in turn has transformed policies globally, such as the World Health Organization's Mental Health Action Plan, the World Bank's Disease Control Priorities Program, and national policies, such as the National Health Policy of India, and indeed, the policies for mental health in the world's richest country, the US as well. At the heart of this approach, widely referred to as task sharing, of course, is essentially the deployment of community health workers, is addressing many of the paradigm shifts I referred to earlier. But perhaps most importantly, and as evocatively described by my friend and colleague, the late Paul Farmer, the community health worker not only offered quality care, evidence-based care, but also accompanied the person with mental health problems on their journey to recovery. This being the single most important link in the mental health care system today. The most important missing link in the mental health care system today, characterized as it is by the lack of information, fragmentation, and the failure to address psychological and social needs, which are so valued by patients and so needed to optimize the chances of recovery. Moreover, there are many other reasons why getting care from someone like you in your community can be transformative and so different from the current system of care. Because receiving care from a person one identifies with, one is comfortable with, who speaks your language, helps build social connectedness, that essential and intangible thread which ties us all together in our community, and which is so crucial for our feelings of belonging and shared purpose. This is, friends, how peer-delivered care is so important. It isn't only a substitute for psychiatric care. It's fundamentally different from psychiatric care. It supports also decision-making that we now know can help prevent involuntary and coercive treatment. Furthermore, such care not only benefits the person receiving the care, but also benefits the person providing the care. Indeed, our programs in India have documented stories of feeling empowered by the frontline provider and feeling fulfilled through supporting the recovery process in others. Above all, it helps address the stigma of mental health care by bringing care to your doorstep without any fear, shame, or crippling costs. I will now show you a 2-minute video that comes from a program that I led along with colleagues in India called the Kopsi Study. And it was a program that wanted to add community-based psychosocial care through lay health workers supporting families and people affected by schizophrenia. On average, the duration of illness was about 10 to 11 years in 3 sites in the country, Satara, Goa, and in rural parts of Tamil Nadu. And the idea really here was to ask the question, does the addition of a community-based model of care improve upon what the care they already received, which was basically antipsychotic drug medication provided by their psychiatrist? We ran the largest randomized control trial of this kind of model of care ever conducted at the time in a developing country. The results were published in the leading medical journal Lancet. But I just want to show you a brief video that illustrates really the experience of this model of care by all the different folks who were involved. Janvi, could you please play the first video?
तसं एकदमच मला कम से कम एक 5 मिनिटं आवाज माझ्या कानाला फिरत होता. मी देव बोलतोय असं तसं.
मानसिक आजार हे काय असतं हे मला याच्याबद्दल काहीच माहिती नव्हतं. म्हणजे हा प्रकारच माहित नाही. मला काहीतरी म्हणजे समायोजित वर्तनात काहीतरी आहे असं मला सारखं वाटायचं. पण कोणापुढे बोलायचं हा एक माझ्या मनामध्ये कुचंबणा व्हायचं.
आजूबाजूची लोक ते दृष्टिकोनातून बघायची तिच्या येडीचे हसती बघा कशी. कोण माणूस पुढनं येणारा असला तरी त्याला असं वाटायचं ती माझ्याकडेच बघत हसली म्हणून तो माणूस असा बघत उभा राहायचा. मग मी ते उभे राहायचे. मी 2-3 माणसांना बडावलेलं बी आहे त्याच्यातनं.
वाईट वाटायला लागलं की झाडाला धरायचं रडायचं. कोणाला सांगायचं नाही पण असं आहे म्हणून.
तसं तर देव वगैरे केले लाख भांगे ले केल्या बरं का. देवाला ह्या देवाला जा त्या देवाला जा त्या अमक्याला पळा कुणीकडे पळा लांब लांब ले जो 5-6 महिने आम्ही राखवलं देवासाठी. प्रमाण उलट देवाला वगैरे जास्तीच वाढायचं पण कमी नाही.
कॉप्सी हा प्रकल्प जो आहे तो त्याचा लॉंग फॉर्म असा आहे केअर ऑफ पीपल्स सिझोफ्रेनिया इन इंडिया. म्हणजे औषध उपचाराव्यतिरिक्त जर काही सामाजिक उपचार पद्धती जर या लोकांना चालू केली.
डॉक्टर आणि पेशंटच्या मधला दुवा असा आमचा रोल होता.
ते म्हणलं पाठवा की सर बरोबर आहे. कारण आम्हाला माहिती येते कसं कसं काय गोळ्या द्यायच्या कशा काय करायचं किंवा काय करायचे कसं त्याच्याशी वागायचं कसं काय म्हणलं आम्हाला माहिती पडेल.
हे तुम्ही जे प्रोग्राम हे ठेवलं होतं ना हां तर त्याचा पुरेपूर फायदा आम्हाला झालाय. म्हणजे औषधांचं तर झालंयच पण औषधांपेक्षा पण ते जास्त म्हणजे संभाषणाने यांच्याशी व्हायचं ना बोलायच्या.
जोपर्यंत जमेल ना तोपर्यंत तरी काम असावं आपल्याला असं वाटतं. जोपर्यंत जमेल तोपर्यंत. दिवसभर म्हणजे काही विचार वगैरे काही येत नाही. दिवसभर याच्यातच मन रमतं ना.
आता जरा बरं आहे आधीपेक्षा बरं आहे. म्हणजे कामाला पण जाते त्यामुळं शाळेत आधी शाळेचा खर्च आधी नव्हता पण आता खर्च आलाय ते मम्मी भावा.
Work is not just for money. It is for self-esteem. It's what you think about yourself. It's the way you spend your time. It's your productivity. It's what you give to society, what you get from society. So when they start working, then they feel much better. People learn to respect them. They start liking themselves.
आत्ताची परिस्थिती आणि त्या टायमाच्या परिस्थितीमध्ये किती आसमानचा फरक. म्हणजे माझं अधिकरण म्हणतंय की इथून पुढे जे तुम्ही चितलेलं काम आहे म्हणजे जे माइंडमध्ये तुम्ही ठरवलेले पुढे लय त्याचं चालना मिळणार.
Thank you. So let me return to closing down, closing my talk now. I'm coming to the end. I want to just tell you a little bit about how my work is now focusing on scaling up this transformative approach to mental health care, really a practical realization of that slogan that many of us are familiar with, mental health for all, by all. Very important for me to stress that again. Mental health for all, by including each and every one of us in the care delivery ideas. Now, one of the biggest barriers to scaling up is the need for scalable approaches to training and quality assurance. And to this end, along with my colleagues in Sangat, as well as at Harvard Medical School, I set up the Empower program a couple of years ago. What does Empower do? It leverages a suite of digital tools to rapidly scale up mental health care through enabling frontline providers, such as, for example, community health workers, peer support workers, nurses, and lay people to learn, master, and deliver evidence-based interventions that are backed by empirical science in the form of randomized controlled trials, such evidence-based psychosocial interventions. Now, many of you may wonder about the word digital. I want to stress here, our deployment of digital tools are not to create yet another app or a chatbot for people who are already struggling with mental health problems. No. Our approach is to deploy digital tools which are system and provider facing to build a workforce, and which will then generate over time large amounts of data that can be used in data science approaches to constantly not just evaluate the impact of the system, but also to constantly improve its effectiveness. Quite frankly, I have become very jaded by the hype around digital apps which are direct to the consumer. Not only is there pitiful little evidence that these apps have made any difference to population mental health, despite billions of dollars of spending, but we also now know that most people who use these apps use it only once or twice. And yet we know that to recover from mental health problems, you need a continuous engagement with the recovery process. We also know that most people with a mental health problem, indeed, most people with any health problem, want a human provider to support their recovery. We wouldn't really turn to self-care apps for breast cancer, and we need to actually put our attention towards not replacing the provider, but building the workforce for people who have mental health problems. Empower's ongoing efforts include the scaling up of a brief behavioral activation treatment for depression, a brief problem-solving treatment for emotional disorders in adolescents in schools, and a parent-child communication intervention for autism. All three interventions were designed and evaluated by Sangat, and all of which are delivered by health workers in primary care or school settings. But here's the really interesting part of this story. Empower isn't just doing this in India in partnership with state governments like Madhya Pradesh and Gujarat, but also now in the US in partnership with implementers in this country. A year ago, Empower was part of a team that included the University of Texas and the Meadows Mental Health Policy Institute, which won the one-off Lone Star Prize in competition with other bids that were addressing other major issues affecting the lives of people in the state of Texas, such as water scarcity and racism. A group of philanthropists awarded us the Lone Star Prize to scale up the Healthy Activity Program, a brief behavioral activation treatment for depression that I mentioned earlier, that was designed and evaluated by Sangat in Goa for delivery through community health workers in Texas. This must surely be a very rare example of how an innovation arising in India has begun to influence healthcare in the richest country of the world. I'm especially excited, friends, by the fact that not only are we taking things from India and applying them in the US, but there are also things that we're now doing in the US that might have some application in India. And one example of that is a partnership we just launched a month ago with the Wellbeing Trust, a very influential not-for-profit in the US, which we call the Strength in Us initiative. And it builds on this whole idea of task sharing by community health workers, but makes it even more democratic, by seeking to empower anyone and everyone in the community to support the mental health and well-being of others in their communities. This program blends psychological science with the fundamental science of social connectedness to create a care delivery pathway that is equitable, efficient, and timely through providing contextualized support to promote mental health and prevent self-harm. And what I'm going to now do, Janvi, is a second very short video before I close. Janvi, the second video, please.
This is mental health. It's how we think, feel, and act. We all have it. It's fundamental to our overall health. And everyone will need help with mental health at some point. It's part of being human. But help is in short supply. Our care system is designed for sickness and crises. And in day-to-day life, people often don't know what they can do to get help, give help, or even where to start. But better is possible. We can have the skills to help care for ourselves and others before things reach crises. To be the first point of support, know what to do, where to start. Strengthen Us is a community-led initiative to help everyone learn basic ways to support common mental health needs. Our communities show up for each other every day. Listen, partner, learn, care. Let's strengthen our ability to say, I can help, in the moment, with people we know best. We're already seeing change happen. People are recognizing it's okay not to be okay. We can take the next step. It's time we have the words to talk about it, the skills to act. You never know how these simple actions could make a big difference. We believe everyone has the power to help. Together, we can be the movement of communities caring for our mental health.
Thank you, Janvi. So in closing, friends, just a few words to say something about this new vision that I'm so excited about. Empower is not intended to replace the mental health specialist care system. I hope you've all appreciated my emphasis on the dimensionality of mental health. There will be people at the extreme end of the dimension who do need specialist support, who do need to spend some time in a hospital. But equally, there is a huge chunk of people who don't. And Empower is really seeking to expand the reach of the existing mental health care system deep into the community, not only to address the vast unmet needs for quality care that people desire and are entitled to, but simultaneously reducing the historic disparities in care and addressing the stigma attached to specialist care. Today, the large and compelling body of implementation and clinical science that supports the effectiveness of community-delivered brief psychosocial interventions has laid the foundation for a transformed vision of mental health care, and one that is perfectly aligned with neuroscience. And that is a really amazing thing. Ultimately, this sends a message of hope that we can move from a nihilistic view about the lack of effectiveness of mental health care to a hopeful, evidence-based view, a science-backed view, in which communities that were labeled as being under-resourced because they lacked expensive and scarce specialized human resources could now be empowered to leverage the resources that every community has. And what is that resource? People who care for others. That, friends, is the heart of the Reimagined journey to recovery. Thank you very much for listening to me. Thank you for your patience. Thank you for being here today. And I believe I'm now going to hand over back to Janvi for a Q&A.
Thank you very much, Vikram. I think this was absolutely fabulous. The registers, as you call them, dimensionality of the problem. I mean, we saw very beautifully the layers that you were able to unravel for us. The layer of knowledge making around disciplines related to the mind, regimes of psychosocial care, health systems, the patient and the caregivers, and how one actually can work through these registers. It beautifully came through in how the relationship between knowledge and intervention and how that spectrum might actually build over time. Last but not least, of course, how an idea from India can travel most usefully. What I personally specifically appreciate is how attentive your colleagues and you are in this program to the tacit knowledge held by community workers and how one might strengthen that in order to create this cadre of people who care for people in extremely good ways. So thank you very much for sharing your ideas with us. I think this was my colleagues and I will agree, we couldn't have imagined a better finale to what is essentially an intervention from the cultural domain to understand the worlds of the mind. So let me begin with one small question before we move on to questions from our audience. The binaries that you speak of, right? Like the mind and the body, the people with conditions and people with non-conditions, the 3Ds that you spoke about. How, and you clearly show us the path forward beyond these binaries. I'd just like for you to elaborate a little bit more about why these binaries come about, what is the nature of the damage they cause, at the back end of the problems that, people like yourself are trying to deal with.
So, the history of the binary, first of all, thank you, Janvi, for those words of appreciation. Look, the history of the binary, actually, I mentioned briefly, it comes to the early 1970s, the desire by the then leaders of the field of psychiatry to reject psychoanalysis and to reject just to focus on social factors, to say, if we are a branch of medicine, then like other branches of medicine, we should also have a diagnostic system. And so, because the diagnostic system was the bedrock of medicine, it's been fabulously relevant to discovery, actually. Having clear-cut diagnostic criteria for breast cancer, for example, has been a very important tool to actually, transform breast cancer from being a really deadly condition in the 1970s to one where the vast majority of women will expect a cure today. I think that transformation could not have happened. And you can see this in every branch of medicine, Janvi. So, it's a model that's worked really well. So the idea was, and it was a well-meaning idea, that, maybe the way to actually, fix this crisis of mental health problems is to adopt the same model. But because we had no biological features then, the approach was, let's start with symptoms that seem to hang together. Let's create a clear boundary between people with and without those symptoms, even though everyone knew there was no clear boundary. We'll construct one by a set of arbitrary rules so that we can then identify a group of individuals, then research them who are homogeneous according to the diagnostic system because they all have that diagnosis. And then we can research that group and find out what differentiates them from the rest of the population. We now know that endeavor has not, it hasn't produced anything of any transformative value. There have been small incremental improvements, of course. I don't want to dismiss that, but transformative, nothing. And that is the history of the binary approach. Now, what's the damage? The damage is twofold. First of all, it's the people who get the diagnosis, it damages them because they become a diagnosis. It's one thing to say you have tuberculosis, but you're not a tuberculous person. But what happens with mental health is, the symptoms of mental illness are essentially things that you and I experience all the time. Feeling hopeless, feeling miserable, feeling worried, feeling tense. These are normal human emotions. And therefore, when you get a diagnosis that is based on normal human emotions, but which have become awry, it becomes essentially diagnosing you as a person. You become a depressed person. You become a schizophrenic person. You become a demented person. It becomes you. And so the stigma is attached to you. You are somehow a faulty individual. But it also works against the needs of those who don't meet the diagnostic criteria because they're not necessarily well. There are people who just fail to meet that checklist, but they're still suffering, but they don't get care. They don't get care because they don't have a diagnosis. So you actually fail both groups of people, those with and without a diagnosis, which is why we need to embrace the kind of dimensional model. And there is a practical, clinical, operationalization of this called staging of care, which I won't go into any detail for now, but there is, in fact, it's not just an abstract idea. There is a practical, translation of that idea.
So we have one young person wanting to know a little more about the book you mentioned, People's Health in People's Hands. Might you share a little bit more with, what you drew from that book, how inspirational it has been for your journey?
Of course, People's Health in People's Hand was published a long time ago, 94. There was a year, exactly the year before I returned to India from Britain, where I was training in Zimbabwe, where I lived and worked for 2 years. And essentially, Dr. Antia, look it up on Google. You'll find it. I don't know if it's still in print, but he had set up a number of foundations in Mumbai and Pune, which were Foundation for Research in Community Health was one of the earliest science-based organizations that wanted to research how India could address its health challenges by deploying its own homegrown resources, its homegrown traditions, and so on. And so there's a series of essays by different innovators in the country, the Aroles, for example, in Jamkhed, the Bangs, in Gadchiroli, and so on. And they just describe these case studies, and the case studies of how these physicians, many of whom, like the Aroles and Bangs, had trained in the US, in fact, returned to India, often driven by a strong rooting in Gandhian values, and returned back or either to their communities or selected villages or communities where there was no care available, and built a care system around the marriage of modern medicine with the intellectual and material resources that every community already had. And at the heart of it, it was the deployment of community health workers. And so I was very heavily influenced by this because I kind of saw these dramatic experiments, none of them on mental health, but they were focused on a whole range of other medical issues. And it struck me that if these innovators could address all these diverse medical issues in this innovative way, well, why can't we do that with mental health? Why is it that we assume that mental health care is so complex that you simply cannot have the community engage in mental health care? And why can't we just bring back what used to be in the 50s and 60s, a strong social psychiatry movement, which saw its zenith in the city of Trieste in Italy, where all mental hospitals were basically shut down, and all mental health care was moved through a network of community-based centers in which the community itself was fully engaged in embracing and including people with mental illness. Why can't this be a model that we can use in India? We already have such strong community networks in place. And so that's how my journey with Sangat began in the mid-90s and really flourished in the 2000s, where we, more than 20 different kinds of scientific innovations and projects that designed and evaluated a whole range of different mental health care interventions. And if you go to the Sangat website, you will find a lot of those described in more detail.
Wonderful. I think it would be a book worth getting back to. And I think for the newer generation, especially to see what the value of this is. Just my limited experience with public health in India, not with mental health systems or institutions, but just public health through a sibling who works there. And often we would talk about how the last mile, in a sense, right? Like the person who interfaces, the everyday experience of medicine is the person who mans the primary healthcare center in a village or in a setting, and in a peri-urban setting, or even sometimes in disenfranchised neighborhoods in urban settings, and that person comes with not the kind of training that one prescribes, but they have a tacit understanding of the community, of the kind of health problems, of the kind of ranging from the sanitary questions of the area to what kind of food has been coming, what kind of food has not been coming, is there a water shortage, is there this, is there that, and their assessment and calibration of providing health care under circumstances of scarcity, often, so the tacit knowledge they embody about their patients and about their settings is so important to be able to deliver healthcare at that last, to the user, essentially, ranging from vaccines to whatnot. And your reading of it, and your intervention over the last, several decades, to use that to also shape mental health care, is, one just wishes you more success for that model to, grow and not just in India, but elsewhere, because one can't imagine a better way to do this. So we have a question from Jitu, from Professor Satyajit Mayer. The message you convey is how people who care for others can solve so many problems related to mental health care, given empirical evidence-based clinical intervention. This is a wonderfully hopeful message. Thank you. Clearly, this underlying message can be used to resolve the crisis of hate and polarization facing our societies in the work today, and in India in particular. How can one attempt to begin to do this? I mean, I think it's
Jitu, thank you. First of all, thanks for attending the lecture as well. I really appreciate having the NCBS director here. So first of all, can I just say, as I know that, you're a fundamental scientist, and as are your colleagues in NCBS, I wanted to say that this actually is a really remarkable historical moment where the fundamental neurosciences and the community-based approach that I talk about are actually completely integrated. I have a piece that we've written with a bunch of neuroscientists that really describes how fundamental, especially network and computational neuroscience, actually speaks to exactly these same ideas of dimensionality and about neural networks, and how ironically this particular conversation that's happening in the labs of neuroscientists also can map almost directly onto cognitive science about how the dimensionality of human experiences, which in turn maps onto intervention science, how interventions that are targeting specific networks in the brain that are mechanistically informed, and ultimately that translates into global health science, which is how can these in fact be scaled up. What are we missing in the middle? We're missing that whole extremely complex process of diagnosis. And by doing that, you're actually therefore making this whole care model a lot more accessible, because diagnosis is, in the way that it's arbitrarily organized right now, an unbelievably complicated process, which admittedly is very hard to scale up. But anyway, turning to your question about hate and polarization, I've thought a lot about that, obviously, because, social connectedness is the heart of, well-being at the level of a society. And both hate as well as inequality are going to profoundly rupture social connectedness. And I think it is a question that really goes straight to our policymakers to try and step back a little bit from whichever ideology they embrace and ask the question, is the implementation of an ideology that divides our community in fact going to affect the majority as well? And here is a really important point to make here. Today you will have seen, or maybe you haven't seen, the horrific massacre that has happened not very far from where I currently am in Boston, where 10 African Americans and a few more are likely to die as well because of their bullet injuries, were shot in a grocery store by an 18-year-old man who was inspired by white supremacy. Now, let's be very clear about this, that not only have Black people died in these terrible numbers, but white people also suffer when they live in a society that is so polarized. They also suffer the consequences of polarization in the form of higher rates of substance use, suicide, violence more generally. And you can see this in the mortality data of white people. If there was ever a proof that hate, polarization, and inequality damages the health of everyone, including those who are currently oppressing the others, then the US is an exemplar of that. And I would say this is the message that we need to be actually embracing. It's not, the message of protecting our minorities, protecting those who have been historically disadvantaged, obviously isn't going to fall on all ears equally. Instead, the message has to be, if you polarize and disadvantage our minorities, ultimately, you, your families, and your own community will also suffer. And if you want a better future for yourselves, let's use a very self-serving argument here, then inclusion and connectedness is the best route for yourself as well. And I use this very this self-centered argument because hopefully I'm hoping that narrative might land on more listening ears than the current narrative, which is just about protecting our minorities, which in my mind is a good enough narrative, but clearly it isn't having the impact that we all believe it should.
Yeah, in fact, I do agree with you completely, and I'm sure many of us do, that why is this important to all of us? And I think establishing that is going to take some effort, and probably we look forward to working with you further on these questions. The next question we have, and in acute awareness of shortage of time, from Alice Bullard, who you might already know as well. So here's Alice's question. Could Professor Patel comment on the boundaries between mental health and socio-cultural conditions like social media, environmental devastation, ecocide, and other maladies of civilization that are often consigned to politics rather than conditions that enable or disable mental health? Frantz Fanon and other anti-psychiatrists sought to break down that political versus mental health divide decades ago, but the dichotomy seems to endure. So what would be your thoughts on that?
Yeah, I think it is a problem, the dichotomy. I agree. You know, I don't see the value of these dichotomies. It's another form of binary. It's either or. Clearly, it's never. That's never the right answer. Just like polarization. You know, there's always a middle ground that where the truth lies. And I think you know, my reading of this is that, you know, political determinants are part of the broader social and structural determinants of health. You know, there's no way we can understand, for example, Ebola without, as Paul Farmer wrote in his beautiful book, his last book, you know, you cannot understand why Ebola broke out in the junction of the 3 countries in West Africa, where it did the last outbreak, without understanding the history of colonialism, you know, the mining, industry, and so on. You cannot understand the Ebola epidemic without embracing those determinants. You can't understand the astonishingly high rates of suicide and alcoholism amongst Native American communities without understanding the history of historical trauma. So I think these are very important, and to provide population level impact, you're going to have to embrace those ideas. But they should never be seen, as some anti-psychiatrists have done, in competition with individual care. You know, because some of the most hardened anti-psychiatrists have almost said there is no need for mental health care, and all the focus should be on the upstream social and structural determinants. I disagree with that binary. I do think people are going to need mental health care. They already do. And the utopia that we would like is unlikely to happen in our lifetimes. And so we still do need to support people who are facing the consequences of those political, social, and structural historical disadvantages because they're suffering now. It's no good, as I often tell my colleagues in anti-psychiatry, you know, this would be equivalent to saying, you know, the way to address the health consequence of domestic violence is to address patriarchy. Well, you know, I completely agree with that. But what about the woman who is currently coming to your clinic with a broken arm, or indeed a broken mind? Are you going to tell her that patriarchy is the problem? No, you're going to tell her, well, I need to fix your broken arm, your broken mind, while simultaneously not pretending that that is the only way for a long-term solution to the problem.
Yeah. Thank you. And I think the last question for today from Krishna, who themselves struggle with depression. And the question they raise actually is not very far from the question that that Alice just asked, which is one of psychosomatism, right? Like, so somatic circumstances and then mental conditions that accompany it. And, if you might have something to say, as Krishna appears to have benefited hugely from medicine and psychiatric care. And what I understand from the way the question is posed is that that the somatic is equally important, that other factors also play a role in how they feel and how they experience their own health, both mental and physical. So if you might have something to say to the psychosomatic, yet another binary that is so so unproductive in some ways.
Completely, John, you said it exactly right. One of the other slogans, some of you will be familiar with it, there is no health without mental health. And, that really speaks to the fact that, this separation of physical and mental health is arbitrary. It's not grounded in science. Indeed, mental and physical health are inseparable. And ultimately, let's be honest about it. Where is mental health produced? It's produced in our physical self. It's produced in our brains. It's, of course, influenced heavily by social environmental factors that we spoke about earlier, but the ultimate final pathway to experiencing all the human cognitive, emotional, and other experiences has to be through our brain. Where else can it be through? So, by that very nature, clearly our mental and physical health are inseparable. The language of mental health is littered, especially in literature, with somatic idioms. I have a butterflies in my stomach. My heart went aflutter when I saw you. What is that? That is a clear reflection of how our emotions affect our physical health. And now we also know our physical health affects our mental health. If I have a very disabling condition, this makes me often feel helpless and hopeless. So these are inseparable, and person-centered care is about providing comprehensive care based on what you need, rather than what is the current model based on the specialty of the provider that you've gone to see.
Time to say thank you, and time to say, goodbye to Psyche. I can't thank you, Vikram, enough for a fabulous close to Psyche. And I, look forward, as I said, and I mean it, to future engagements with you and with others who have worked with us so closely during Psyche. So thanks for joining us this evening. Our biggest thanks, of course, go out to our founding partner, the Government of Karnataka, and our academic partners who continue to support our fabulous work. And thank you, Jitu, for attending today's lecture as well. The Indian Institute of Science, National Center for Biological Sciences, Christie Institute of Art, Design and Technology. A big thank you to our academic and curatorial panel, Richard Wingate, Sanjeev Jain, Ulrika Kluger, and of course, Vikram himself, and the 4 curatorial advisors, again, from, different parts of the globe. Partners on this exhibition, the National Institute of Mental Health and Neurosciences, the Wellbeing Project, which Vikram also mentioned, Museum Dr. Gislac in Ghent, and the India Alliance for continuing to believe in our public engagement programs and continuing to support us over our exhibition seasons. Thank you to our youth advisors, because without their mentoring, we would in many ways not be able to find ourselves in a situation where we are able to share what we ourselves have learned in the making of this exhibition with our audiences and with young people. We run a film festival alongside every single exhibition, and we often reach out to people who understand films, the landscape of films of different kinds, from animation to documentary to features, far better than we do. And so thank you to our 3 film advisors. The exhibits from the artists and scholars without whom this exhibition would not happen, many in number. Thank you very much for all your effort. We had 25 public lectures, and these will continue to be available on our website, on our YouTube channels. So, feel free to pick them up and run them in your classrooms, run them in your, neighborhoods, wherever you would like. These are talks, like tonight with Vikram Patel, but also, other scholars who approach the mind, from different perspectives, historians, curators, artists, patients as well. So the lecturers, as we have them here, the 6 films, their filmmakers and the scholars who discuss the films with them, do have a look at the discussions. And I'm glad Alice could join us this evening. She was one of the discussants. 9 workshops and 6 masterclasses. The facilitators, thank you very much for making our exhibits and our public lectures and other parts of our work accessible to our young audiences. Our events and the facilitators of the events, as you can see, the numbers run often into miles. Without all of this, I think the layers and the richness of our programming would never be visible. A big thank you to our translators for allowing us to make our exhibition available, exhibition and its contents available both in English and Kannada for better reach. We are committed to increasing our Indian language outreach in the years to come, as we develop better capacity. Our mediators, the young people who actually give online walkthroughs of the exhibition through and 90 sessions over 45 days, their energy is infectious. And I look forward to working with many of them in the coming exhibitions. So here are they. Our experimenters this was a pilot program we ran this time, who worked very closely with us and developed some of the exhibits and the programs as well. My own team, without whom nothing is possible, of whom I'm very proud, and I, enjoy your energy. Thank you for what you bring to the table. The curtain falls on Psyche. Thank you for being a part of our journey. Thank you for coming to the closing event. And we will be exhibiting Psyche, a small part of Psyche at the Wellbeing Summit from the 1st of June to the 3rd of June in Bilbao. And stay tuned for the next exhibition season. Thank you very much, and have a good evening and a good morning to Vikram.